Well, hello, everybody. My name is Garrett Schmidt. I'm the CEO and managing editor of BBC Exhibit Hall, and I'd like to welcome you all to today's live webinar, which is part one of a two-part series called DIY MSSP ACO Reporting, and it's hosted by MRO. And today's session is again part one, and it's called Requirements and Strategy Foundations. And we're going to have a lot of material to cover. So I'll get right to it here. A few items of note, though, before we get started, a few housekeeping items. We are going to have a time for some questions, so would love to hear from you. And at any point during the presentation, you can drop those questions into your attendee module, and there's a place specifically for questions there. And we're going to get to as many as we can. If we're not able to get to yours today, don't worry, someone will reach out to you via email afterwards to make sure that we get your question answered. Also, the session is being recorded, so what's going to happen is when we conclude, maybe an hour or so afterwards, you're going to receive an email, and that email will have a link to the recording as well as to where you can download the slides from today's presentation. So with that, I wanted to briefly introduce our speakers today, and then I will turn it over to them. With us, we have Mr. James Pelletier, and he is the National Director of Provider Quality with the MRO. And we also have Mr. Bhushan Kadu, and he is a Senior Manager of Account Management with MRO. So welcome, gentlemen. I'll turn it over to you at this time.
Thank you very much, Garrett. Welcome, everyone. Happy to join you and have the opportunity to discuss something that we've been working on for quite a few years now at MRO. Love to tell you a little bit more about myself and then hand it to Bhushan and allow him to introduce himself. We'll get into some introductions on MRO and kind of who we are and what we do, but mainly focus on kind of the part one of a two-part series, which is requirements and strategy. If you are to take on the challenge of self-reporting going forward as an MSSP ACO, based on our experience, what are the things that you should be aware of and anticipate in order to ensure that that goes as smoothly as possible. So myself, again, my name is James Pelletier. I've been in healthcare for over 20 years. I have specifically been focusing on population health over the last 13 years in a variety of different use cases, almost always focused on data and analytics. But the great thing about working with value-based care organizations, as I have, they tend to be very innovative, and many of the solutions that I have worked on are with the goal of improving things like care coordination, patient engagement, quality, lowering costs, all the things that, of course, you as a value-based care organization are focused on a day in and day out basis. So I'm happy to be here, happy to provide any expertise that I have. Bhushan Kadu has been with MRO for a lot longer than I have. I've been here for about 3 years. He works with our customers on a day in and day out basis. So we work hand in hand to ensure that our customers are getting the value that they expect out of our partnership. So with that, Bhushan, love to hear a little introduction for yourself.
Thank you, James. So I have around 20 years plus experience, majorly into data analytics and delivery part of it. For last 7 years, I have been with MRO, specifically handling the healthcare projects. It has been fun, a lot of challenges. My job is basically to work with my customers, understand their pain points, and try to solve those. In my experience in last 7 years, what I've seen is the challenge is basically to extract the data, normalize the data, and then produce it into the dashboards and eventually submitting the data to CMS. There have been like a lot of ups and downs. We understand the problems. Of course, there are always solutions, but the core part is the pain points that people go through it and have that experience. So I'm here to share some stories here, my experience, what's good, what's bad, and we'll talk about this in the next 1 hour.
Yep. Awesome. Awesome. There's no limit to the number of different projects and things that Bhushan gets pulled into. So his wealth of technical and strategic experience Again, we'll talk a little bit more about MRO and sort of all the types of things that Bhushan and many other people on our team are working on. But rest assured, again, he's the guy that makes it all work for us and for our customers. So we're very appreciative of that. With that, we want to start off with a poll question. And I want to take the opportunity before Garrett kind of takes over to reiterate what he said. Some of you have more experience than others, and I think we're all here to learn from each other. So whether you have a comment or a question, please feel free to utilize the chat as often as possible. We won't get to your questions till the end, but we usually do leave enough time to be able to address many of the things that are kind of top of mind for you all. So I know that the audience is from a variety of different backgrounds and maybe different interest levels. So if you're at an MSSP ACO, again, love to hear from you, whether you're going through this year for the first time or you have experience in prior performance years as well. So polling question, I'm going to hand it over to Garrett, and he's going to allow you a minute to respond.
30
and
minutes.
one thing I
We'll
will
have 30
say,
minutes to...
Garrett, when we talk about experience, we want to ask about prior years. So if you've already gone through a submission in prior years, love to hear again where you kind of fall in this kind of, and all the options relating to your experience having done this before or not.
Yeah. All right. Well, you should all see this on your screen right now, and this is anonymous, by the way, and we're going to have several of these throughout, and we'll show the results. So this is kind of more for you to see where you stack among your colleagues and how things are going in the industry. So it looks like the results are coming in here. We're going to give it another few, maybe 10, 15 seconds in order for these to all come in. And the question is, are you an ACO with experience submitting eCQMs, MIPS CQMs, or Medicare CQMs? And first choice, submitted successfully in prior years internally, submitted successfully in prior years with vendor qualified, have not submitted yet, but plan to submit ourselves, have not submitted, but plan to work with vendor qualified. And then the last is unsure. And then I would also put NA in there. So if this is not applicable, if you're just joining us, but you are not an ACO and you're just kind of curious about, go ahead and maybe click unsure there. And then we'll give it another 5 long seconds and share the results here. Maybe 5, 4, 3, 2, and 1. All right, James, are you able to see those responses? And if you could read out the results for those who might be calling in.
I would love to have Bhushan call those out for me if he can.
This is not a surprise, James. This is what we expected. There are a lot of ACOs who are doing the submissions internally. They have done this in the prior years. Almost 40% of them are already doing that. And the next ones are they have not submitted, but they plan to work with some of the other qualified vendor registries. Okay. And there's another big chunk that I foresee is people are not really sure about it, 20% of them. So probably this session would help them make that decision about it. And then the rest are like 11% where they have submitted in the past years with a vendor or a qualified registry, and have not submitted yet, but they plan to submit. So there are 11% of them as well. So I think it's a great mix. And top is they have already done that internally. And I think this will be a great platform for all of us to, share our stories, what are the pain points, and let's share that knowledge across everyone. Great.
Absolutely. Again, a good mix, I think. And I think we're always learning, and this is a kind of always changing thing that we're working on. We've seen many changes throughout the years since these new requirements were first introduced. So I can remember back in 2021 when it was the first optional performance year for organizations to start to submit via the new methods. And at the same time, most were still doing web interface reporting or GPro reporting. And but we're now 4 or 5 years away from that, and now we're in that first required performance year. And again, I think many people that maybe know us already or have talked to us may be wondering why we're having this type of conversation, because ultimately we sort of fall in the have submitted and worked with a qualified vendor or a vendor slash qualified registry. So I want to talk a little bit about MRO, a little bit of a sales pitch. One of the things I always say about us, if you've ever talked to me before, is that we are an option for groups that are looking to report via the new eCQMs, Medicare CQMs, and MIPS CQMs. And we're just one of the many options, including obviously organizations that are doing it themselves or working with another vendor. I tend to want to distinguish ourselves as being much more of a partner than a vendor. So I'll talk mainly about our differentiators. And again, talk about our experience and the health systems that we work with. So for some of you that know MRO, you know that we are focused on clinical data exchange. We work with hundreds of health systems around the country in a variety of different use cases. One of the best known use cases that organizations know us as is for our release of information business. We've been doing that for well over 20 years and are responsible for the incoming requests for clinical data that a hospital receives on a daily basis. We've achieved best-in-class status for many of those years, and ultimately our customer retention sort of speaks to the level of trust and partnership that we provide, and ensuring that this very important clinical information is getting in the right hands in an efficient and timely manner. We also are, and I think I might have skipped a slide here, working with organizations via our registry capacity. So focusing on the automation of extracting clinical data for the purposes of MIPS reporting, quality reporting, sharing clinical data for utilizing it for research purposes and clinical trials, et cetera. So going back to this slide, some of our kind of things that we've earned, accreditations, certifications, et cetera, again, that are important to our customers and underlie the trust that we've earned from our customers in ensuring that clinical data is usable and has integrity relating to where it comes from. So I like to talk about our class certification. I know Bhushan has been close to our HITRUST certification and our NCQA certification as a DAV vendor. So maybe he can share a little bit more about that and how proud we are of that.
So of course we we are HITRUST certified, and security is the number one concern nowadays. You must have heard the story about the ransomware which happened last year, and so people are very careful about it. We go through. I understand, we go through 2 or 3 audits, two or three security assessments by different teams. So this is always a channel, always a fun to get this new questionnaire, fill it up, provide them, have discussions with them, so that our customers do understand and then uh, trust us. I think that's the most important thing. I'll probably like to add one more point here. There was a very strange requirement which came up as our customer said, we need to have a clean room, which is like a physical clean room where even the cell phones are not allowed, no camera phones. It needs to be access controlled. The data needs to be isolated. So that was again a fun project for us to make sure that we deliver that within the timelines. This came as a surprise, but this was kind of a requirement, and we were able to deliver this. Coming on to the NCQA ONC certification, uh, we are we have got 18 HEDIS measures which are already been certified. ONC, the numbers, almost 150 plus measures have been certified with us. So it's a great mix of measure development, a good quality security, which encompasses, like, the trust factor into our system. James, you want to go
Yeah,
ahead?
absolutely. So when we talk about how we look at MSSP ACO reporting, we are, we're utilizing technology and services that we've built over a long period of time, even beyond before 2021 when we first started working with an
Yeah.
ACO that had multiple EHRs, and weren't one of the lucky ones, and that would be the MSSP ACOs that have one EHR, and so we we have been utilizing technology that allows us to connect to EHRs in a much more intimate way than most systems out there. We'll talk about QRDA1 files as kind of being the standard for exchanging data or getting this quality clinical data out of EHRs. But our expertise and familiarity with EHRs and lab systems and PM systems and our data aggregation platform is really what separates us from a technology perspective beyond just consuming flat files and calculating measures. So when we talk about performance pathway, we think about all the different data sources and where it could exist, and all the different workflows and scenarios that exist for you as an ACO. Some of you may have 5 EHRs in your ACO, some may have 200 plus, and who knows what versions are they certified, all of that good stuff. All of these different moving parts are very, very complicated. And that's something that we help solve through the technology that we've built that allows us to pull data out of EHRs, understand data at its source, and ultimately calculate the measures that you're looking at and relying on. Our goal as a platform is to maximize performance, and that's how we do that. Through a combination of technology, services, and partnership to ensure that you're getting the credit for the quality of care that you provide, and not just based on the documentation that was provided by your physicians, all with the best intentions, but with so many different workflows, EHRs, etc. Our technology and services are all designed around helping organizations, helping ACOs manage that and take on a lot of that burden and responsibility. So unlike, again, a lot of the vendors or qualified registries that you may be familiar with, we are working on a day in and day out basis to ensure that data that's coming in is accurate and ultimately will result in a high performance and ultimately increase shared savings. So I've kind of glossed over this a little bit, but this is kind of, how we think about the different level of service that we provide and that those differentiators. Bhushan, I know that you've been through a lot of implementations with over 70 different ACOs at this point. What would you say is the most challenging part for groups to kind of get their hands around, even working with a vendor like us, but maybe for someone that's doing it themselves? What are the kind of the categories that you think are most important?
Uh, the number one challenge that we face is acquisition of the data. Now, getting that data across to any third party, or uh, releasing that information is the critical part of it. But at the same time, this is the most important thing. And once we get that data, you get the data, you put it into your pipeline, and then you publish the dashboards. And when it comes to the review part of it, that is where that is where you start seeing problems,
Mm-hmm,
because we don't know what kind of data is being documented, and junk in junk out is kind of starts showing up.
mm-hmm,
And talking to the practice, actually talking to the practice and understanding the documentation formats, the documentation processes, because every practice has got their own way of documenting.
mm-hmm,
um, and then putting that into a standardized way, normalizing that data is, of course, a greatest challenge. So these are the two things that I feel needs a lot of attention to detail. One is the data acquisition. The other one is the refinement. We call it as a refinement process.
Yeah.
So that's very interesting.
Yeah. A lot of people are surprised to know that we do communicate at the practice level, and it's not just the ACO's responsibility to ensure that gaps are filled or that data is flowing as it should. We all know that providers are providing great quality of care, but I think the biggest thing here is matching the actual services provided with the numerators and denominators that are all part of these calculations. And so it's that end result that determines, again, how you perform. But there's a lot of different variables and kind of a lot of balls in the air for ACOs that are taking on that responsibility. So that's kind of maybe a preview of some of the things that we're talking about as we kind of shift gears a little bit into, again, as an ACO doing it themselves, what are the things that we would focus on? So let's talk about this problem. And it's a problem, it's an opportunity, it's something that I think a lot of ACOs have been looking to push off for as many years as possible, but it's a big change. And if we look back at prior to 2024 and the GPRO reporting requirements, 10 measures, and you are given a sample at the end of the year of 250 patients that you need to report on for each measure. And again, I know I'm preaching to the choir for many of the people on this call right now. That tended to be a very end of the reporting year type of activity. With 2025 and the new requirements, it's requiring a lot more work up front and during the year. And it's relying on a lot more strict data. It's data for all patients, all payers. If you're doing eCQM or MIPS CQM, it's just Medicare patients if you're choosing the Medicare CQM route. But still, the volume of patient is much, much higher than it was before. Although, at least for 2025, they have narrowed down our list of measures to just the 4 that we see on the right-hand side of the screen. So the measures themselves are pretty familiar to most groups that are in value-based care. But it's this challenge of how am I calculating my scores for each of the different ways of submitting, and how do I ensure that ultimately if CMS does audit me, I can stand behind the calculations that I've submitted and done all the different steps that are required in order to successfully submit and be proud of the quality of care that you've provided. So when I think about the new APP Plus sort of challenge is, first of all, there are 3 different methods of submitting: eCQM, MIPS CQM, and Medicare CQM, and they're all utilizing the same 4 measures, but they have different requirements. First of all, eCQM and MIPS CQM, it's all patient, all payer requirement. So not just your Medicare population or your senior population. You're reporting on these 4 measures for that entire group. If you choose Medicare CQMs, you are only reporting on eligible Medicare encounters. But each different level kind of has different incentives in place as well. So these are options that have been extended through 2028, and essentially Medicare is encouraging groups to go the eCQM route and incentivizing you. So although many groups may think it's an all or nothing submission of one of those 3 options, our customers are typically evaluating all 3 different ways of submitting and choosing the one that's most advantageous as far as a balance of the quality score and those incentives. So although you may not score as high via the eCQM submission method, it may still be advantageous for you to submit that way versus Medicare CQM. The one that we see most often is that often utilized as a Medicare CQM is depression screening, but most of the others we see are relatively similar in terms of how each of those different methods ultimately calculates how you submit. The next thing I do want to stress is, again, how do eCQMs differ from CQMs, those other 2 options. CQMs allow you to do a chart review. So if you have groups that are not yet on certified EHRs, or if you um, know that there's information within your physician notes that is not in a structured data field, you will get different scores, again, for CQM calculations versus eCQM. So that's another reason why some groups are looking at CQM as the easier option, because it's not simply dependent on the structured data fields in the EHR. So, Bhushan, of these measures, I know that some of them are more challenging than others for some of our customers, but can you speak a little bit more to those specifics?
For sure. Let me take the depression measure. I think that's one of the biggest pain points. Uh, I think the problem starts with acquiring the data itself. There are a lot of practices which are not ready to share the depression data, uh,
Mhm.
because it's pretty critical and non-shareable data. So there are chances, like, the data comes, the only the um, depression data comes through a different channel. Like,
Mhm.
you are getting all pair all patient data in a different way, but you get the depression screening data in a completely different channel. And we have to make sure that we integrate that these two different channels, and then identify those patients, and then have a longitudinal data for that particular patient, so that measure computations are clear.
Mhm.
So plan of care is a section which we may get, we may not get. So that's always a challenge of even EHR releasing that data for us.
So the
Then,
gaps is beyond just the flat files. Where else can
yeah,
we get data? Because oftentimes there are gaps. It may be just that
correct,
it's not a structured data field, or it's in a different system, things like that, right?
correct, right.
So different
In fact,
physician work challenges, right? And I'm sure
yeah,
many of the people on the call are understand that. Standardization of documentation is always been something that we're achieving, but with a number of physicians in a practice, and again, physicians coming in and out of practices, a lot of times you have to account for those different workflows.
yes.
Yeah.
I think there's one more great example of, cancer screening measures where
Mhm.
um, the provider will normally, like, just ask a basic question, like, when was the last screening done? And the patient says, oh yeah, it was done in like 2023. So he just documents into the note section that breast screening done in 2023. Now, acquiring that data from the notes and making sure that there's a credit which goes through, it's something always a challenge.
Yeah.
Of course,
It's hard to
you
know what
just
patient. Yeah, you're looking at all of your not met patients and having to sift through all of those notes in order to find those needles in a haystack where that data actually exists. Yeah. All right. Just based on time, kind of moving along, we don't know what the future holds. I know that probably things will change, but the thing that we're anticipating, based on what we know so far, there hasn't been any changes this year, but there were a few changes last year. So we have new measures getting added over time. One more next year, another one in 2027, two more in 2028. And then there's potentially bigger changes in 2029 and beyond. Um, I know that for for an organization like us that's very familiar with building measures, this isn't necessarily as much of a challenge as it might be for groups that are doing it themselves, Bhushan. So can you speak a little bit to those measures as they continue to get added on, what those potential challenges are in terms of data elements and new things that you're looking to
that's
build standardization across?
Yeah. So adding the new data elements or capturing that, it's definitely a challenge for for a new measure to be introduced. Whether that particular practice is doing that in the correct way or documenting in the correct way. I'll probably throw up an example here where uh, where what we have seen is, we have introduced new measures, and the providers were documenting older code or a retired code. So
Hmm.
they were treating the patient the way it is supposed to be treated, but the credits were not being given to the practice. Now, what we did was, we understood like, okay, these are the list of codes that are being retired and then they are being given back. So we go back to the customer and tell them like, oh, this is something that needs to be given as a feedback to the providers.
Hmm. Yep. I think again, codes change, interpretations change, so that's something to keep our eye on. And again, we can anticipate for next year and kind of plan ahead. One of the things that we learned through our onboarding process with our practices is, as much information as we can provide to practices, to their providers. Here's what to expect. Here's the new measure. Here's where our EHR expects that data to be. Here's the codes that you would utilize in order to make sure you get credit for that. So being as proactive as possible, I think is good feedback on that as well. And along with the 4 measures, of course, that we have for today. So when we looked at our solution, and when you think about this, the first part is how do we acquire the data? So again, I've mentioned the QRDA1 as a flat file that is supposed to contain all the quality data needed in order to report for your ACO. I think some EHRs are in varying stages of being ready to be able to produce those types of files. If they're certified, they are supposed to have that capability as part of their certification. But one of the things that we should mention is that Medicare doesn't necessarily care how you get the data. All they care is that the data hasn't been manipulated between where you calculate where you do your calculations and the source. So we have utilized QRDA1 files, CSV files, Excel files. We kind of put that in that push category where organizations are pushing this data to us on a monthly basis, where there are capabilities for some ACOs that may have enterprise data warehouses already established where you have some API to your EHRs and you don't necessarily have to
Yeah.
rely on those types of push files. So that's an option as well. We've certainly utilized those, and what that gives you an opportunity to see is information that wouldn't necessarily be part of a QRDA1. So documentation in the wrong place, information and notes that you wouldn't otherwise be aware of. So understanding that you as an ACO are maybe have already established different technologies and solutions, some of those more than likely you're looking to utilize if you're already connected to some of these EHRs for quality reporting purposes. So I will mention that. This is a slide that I just put up because, again, it speaks to the nature of the beast. Your clinically integrated network has more than likely many different EHRs, multiple versions of EHRs, and that's hard to manage. And so, understanding up front as much as possible, what versions do I have? Where are some of the gaps that may exist before we start this program? If we were to submit today, what would it look like? Um, that is encouraged as much as possible. Have as much runway early in the year to know where you stand and to have time before the end of the year to improve your performance and identify gaps early so that they don't become a bigger gap than they need to be. And I know Bhushan, again, experience having worked with all of those different EHRs with lots of different practices, solo practices, large health systems, all with different capabilities and expertise. And you can imagine, I know that many of you know this, those solo and 2-doctor practices don't necessarily have the time or the expertise or the IT kind of background to handle all of the work associated with getting you this data. So we definitely find that working directly with the practices helps with that. The next topic, as we talk about strategy and data validation, I think is a big one. One of the things that I heard at the NACOS conference in the spring from an organization, a panel that was discussing this, is the need to validate. And it was validate, validate, validate. Do it early, often, and understand, again, how am I performing? So for some organizations, for all organizations, we would encourage that you are measuring how you're performing constantly throughout the year. Now, perhaps not real time, but near real time, at least on a monthly basis. Um, what you'll find as you are reviewing your results, and if you have a solution that allows you to view your results on a provider basis, you're going to see that some providers perform lower than others. And that's where we tend to focus our attention. Why is that? Where is the data? And how can technology perhaps solve this problem, and or some additional education to that provider to help them understand what codes are required where, or whatever the case may be in terms of depression screening always being in the notes, but it should be in this required field. Bhushan, again, you work hand in hand with our customers, so it's again a lot of balls to juggle. So if you have any thoughts or wisdom on this piece, we'd love to hear it.
Oh, I think the biggest takeaway from this slide is on the patient care gap. That's where the practices run for. They want to see the list of patients who are not met, which is close to real time, so that they can go chase them, bring them down to the practices, and make sure that the corrective actions are being taken, and make sure that their performance increases.
Mm-hmm. Absolutely. And again, we try to start measuring right in January. Although we may be working on the previous performance year, most of the work's been done for the previous performance year, and we're kind of looking at the new measures as we implement them, and how can we improve performance.
Yeah.
The next topic is patient deduplication, which is something that CMS has told us is a requirement, but they haven't necessarily told us how to do that. So it's something that you shouldn't forget. Thinking about, is my process, if I'm doing this myself, is this audit proof? Did I do my calculations correctly? It's obviously a lot more complicated than just a numerator and denominator. It's exclusions and exceptions in terms of how are you actually calculating your performance, and deduplicating your patients across multiple EHRs. If you don't already have a system in place, like an MPI system, that can be a challenge that you want to understand upfront, and again, have some system in place in order to do that patient deduplication. That's going to improve your results. So the less duplicate patients you have in your quality performance, the better. But you don't want to create a lot of work where there's a lot of near misses as well. So that can be a balancing act. We found that some organizations will use up to 3 attributes, and maybe 4 or 5 for others. So it all depends on their tolerance for kind of handling some of those near misses, where patients are using, and for me, maybe Jim instead of James, or some other variation that requires someone to take a look. So we've talked about this. Again, it goes along with the need to validate. Having a dashboard and the ability to be able to measure your performance as you go is extremely important. You want to be able to see, how is a particular practice performing? How's a provider reporting? How am I looking at the ACO level? How does potentially looking at an eCQM submission affect my quality scores versus submitting via Medicare CQM? So these are all the different types of things that we like to see in our dashboards, so that we can target and look at those gaps that we can be proactive with and help solve for, and B, looking at our options of different submission methods. So having, and one of the things that we haven't mentioned as far as requirements is the need to report on all of the MPIs within your ACO. So that's every billable provider for each of the TINs within your ACO, not just your primary care physicians. Specialists, mid-levels are all part of this reporting as well. So having the ability to break that down to a very granular level, and then get to the actual clinical data that's being received is something that, again, hopefully you've considered or are considering as you perhaps build this yourself or look at some other solution where you're going to be doing this yourself manually. So we're getting into poll questions. We're at 40 past the hour. Want to get you involved again and then kick it off to Q&A pretty quickly after that. So first poll question is, how many EHRs do you have in your ACO? So love to hear about, the complexity of your specific ACO, and we'll kick it off to another question after that.
All right, great. You should be seeing this on your screen here, and same as before. How many EHRs do you have in your ACO? We know not everyone is part of an ACO that's listening in today, so we have an NA choice at the end there. And if you're joining us later, this is anonymous. We're going to share the results, so you can kind of see again where you are among your colleagues. And we'll give it another minute here for the results to come in. I think most folks have joined at this point or have responded at this point, but give it another maybe 10 seconds, 5 long seconds maybe before we conclude. Okay. All right, I'm going to go ahead and close it down here. All right, James, Brushan, are you able to see the
Oh
results
yes.
here?
So I see the uh, between 2 to 5 EHRs and 6 to 20 EHRs, they are consuming almost 28 and 28%. So these are the two top ones. There's
Yep.
19% for 20 plus EHRs, which looks like a bigger health system for me.
Mm-hmm. Yep.
And there's only 9% of the people who have single EHR.
Got it.
Yeah.
Got it. So that makes sense. Most of the people that have one EHR would probably not be as attracted to a webinar like this. Again, when you have one EHR, that's one QRD, one file. Every patients are already deduplicated within that system. So their challenge to report is much different than organizations like we have on this call. And we probably could have had EF because some are 100 plus EHRs, 200 plus EHRs, and the challenge, I guess, only multiplies when you consider, again, all the different scenarios that exist that we've spoken about so far today. And by the way, we've been talking about strategy and data validation and things like that today. Part two of our webinar is coming up in a couple of weeks, where we're going to talk a little bit more about sort of the technical component of connecting to these EHRs, some of the compliance issues that you should expect. So a little bit more of the data aggregation and submission files and things like that. And so just want to throw that out there.
Yeah, and actually to that point, I just put a link in the chat to where you can register for free for part 2. So you can download that. We'll also include it in the thank you email that we send out, but go ahead and register if you would like. All right, let's get into the next polling question, and I'm going to pull this up on your screen as well. This will be the final one for today. What do you think is your biggest challenge in eCQM, CQM reporting? Is it acquiring EHR data, validating data gaps, deduplicating patients, monitoring performance, or other? If it's something other than that, go ahead and drop it in the chat, just out of curiosity. We'll see what that is. But again, this is the biggest issue that you're facing. I know there's you may say, well, there's several of these things, but if you had to choose one, what would it be?
Mm-hmm.
And
And this is for groups that have experience or are anticipating. What do you anticipate to be your biggest challenge, and/or what has been? And even if you do answer A, B, C, or D, write in the chat, a little bit more specific. Love to kind of dive deeper into that, and again, learn from each other and see what you guys are thinking about.
cool. I'm gonna give it another maybe 10 seconds, and then we will close it down here. And then we'll have some time for some Q&A here shortly. All right, I'm going to go ahead and close it down and share the results. There we have it.
So James, no surprise again, like acquiring EHR data is on the top of the list, and then validating data gaps. Second, deduplicating patients is number three.
Okay. Interesting. Well, fill up that chat. We're about to get into Q&A in a minute, but I want to leave enough time. So um, I, I think again things that we thought we knew, and thank you for validating that. It's an ongoing challenge. Things are going to be changing going forward, and we're working in a world where it's always a moving target. So again, I mentioned some of the variables, adding providers, adding uh, new practices to your ACO, different workflows, different versions of EHRs. So welcome to the world of eCQMs and kind of where we're going in terms of quality reporting. If you're not an MSSP, stay tuned because you know that MSSPs tend to be the guinea pig, but these types of requirements are more than likely to come for other value-based care programs as well. So the sooner we can get good at this, the better I think we all will be. So key takeaways: accurate data drives value-based care success. I think that's goes without saying. We focus on two things in value-based care, and that's quality and cost. And data, bad data in is bad data out. The process of reporting for your ACO is not necessarily to change how physicians are practicing, but just ensuring that you get credit. Automation as much as possible, allow technology to do some of this work wherever possible. So consider some of the solutions that we've mentioned that would help you aggregate QRDA1 files, create your dashboards, and then implement strategies for reducing those gaps and ultimately improving performance. So without further ado, I do want to get to Q&A. So I think that is Bhushan still on, or Garrett, maybe you can provide some of the questions that appeared in the chat because I can't see them. But
Sure thing. Yeah. All right. Well, let's get into those in no particular order here. The first one is what type of hidden costs can we expect to encounter throughout the year that we might not be considering?
great question. So hidden costs, I think one of the biggest ones to consider is, am I able to do this myself without hiring any more staff? So, for a lot of organizations that are used to reporting the old way, oftentimes people within the ACO would be redirected in February and March in order to go through that manual process, and everything else that ACO was trying to do was kind of put on the back burner while everyone was focused on that individual task. This process is much more of an ongoing challenge. So when you are considering taking on all of this yourself, you're looking at, again, how many people do I need in order to manage the complexity of my network? How much attention and time do each individual practice need? How much time do I need to spend actually looking at the data and identifying gaps versus going out and actually creating the processes that will prevent those gaps from happening in the future? So definitely staff, what do I need to staff? And then what other outside solutions do I need? I think actually one that I probably should have mentioned second is, how much is my EHR company going to charge me for this? Whether it's a QRDA1 file or some other request that you have for your EHR, oftentimes they are charging for those flat files as well. So things that we help during the implementation process, kind of help organizations get a grasp of, is not only the fees that we charge, but what are the other costs that we can't control.
Okay. Next question here. And by the way, if you have a question that you would like to ask either of our speakers, I don't know where Bhushan went, but if he's still with us, he is. Go ahead, there he is. You can drop those questions into the, there's a little module specifically for questions, which is different actually than the chat. So go ahead and drop it in there. We're going to get to as many as we can. Next question here is are there any upcoming policy changes from CMS that could impact reporting in the next year?
Um, I think we don't know. There's been a bill that has been in Congress for a while that would have delayed the new requirements. Uh, we're well past the point where people think that that's going to affect this year. But again, I think the predictability of new requirements or changes to the program is hard to predict, to be honest. What we've seen so far is that this performance year being the first required performance year that you must report this way. Again, we're at the point of no return, so we're all going to have to do it for the first time if you haven't done it already this year. But could they end the program next year or the year after? I would doubt it, but who knows? Different administrations have different um, priorities. So one of the things that I can say is that these requirements, although they have changed and been tweaked a couple of times, they've been pretty consistent through multiple administrations. Um, but again, I think we did a timeline earlier. There's probably going to be one more measure next year. Maybe they'll add another one and kind of add that to that we weren't anticipating. So be prepared to pivot because more than likely there will be some kind of tweak. But major tweaks, I think we're past that point.
Good. All right. Next question is this. Why is attribution essential for eCQM's performance, given that eCQMs are all patient, all payer?
I'd love to have Bhushan's perspective on that one.
Okay, so all payer. So when I say it is attributed patients, attributed patients are purely focused only on the Medicare beneficiary list and not really for all payer all patients. So eCQM is definitely for all payer all patients. Medicare is only for the beneficiary list, and that's so the way we used to have for web interface earlier, we used to get 616 patients per measure for 10 for all the 10 measures. So we used to have roughly like 2500 to 2600 patients as the beneficiary list, but right now for Medicare it can be ranging into the size of probably 5,000 to 10,000 patients as an attributed patient list. So but at the same time, for eCQM reporting, purely eCQM for the eCQM measures, uh, I have not heard about attributed patient list.
Yep. I think part of it is, do they have a qualified encounter, right? Do they have they triggered and ended up in the denominator
Mhm.
whereby they would have a scenario that triggered a depression screening or breast cancer screening and things like that too. So although it is all patient all payer and Medicare only, it is obviously for the ones that you have an encounter with throughout that performance year.
Yeah.
Great. Next question is this. How do successful ACOs align clinicians and staff around measure improvement?
Again, Bhushan works hand in hand
Yeah.
with practices. One of the things that I would say that Bhushan does well is being proactive.
Yeah.
Whether it's educational materials or just having an understanding of their workflow or their EHR
Yeah.
versions and sort of that type of experience. He generally knows how to fix problems even before they finish telling them about the problem. But we're also, you have to have flexibility as well.
Mm.
Wherever possible, if technology can fix a problem rather than you changing the way a physician wants to document, and maybe you're getting resistance there. Change management is, something but so getting that
I,
buy-in and that education out there, I think is important. Go ahead, Bhushan.
I like to add, when we say proactive, so if you are moving into this ACO world right now of doing this submission for eCQM reporting, always try to have checks and balances at a very regular interval. Now, when I say
Mhm.
checks and balances, it means that you make sure that you are getting the data from your EHRs at a timely basis. We have a pipeline where we cannot just monitor each and every data connection, how the data is coming, and whether it is coming every month, every day or not. But there are always checks and balances you put in place where an alert comes up saying that, like, oh, we have not received data for this particular practice from this EHR for last 15 days. It's a it's probably a time to go and check with them what's happening. So having this uh, checks and balances in place really helps you to make sure that your performance is monitored and then improved over time.
Mhm.
Gotcha. I think we have time for one more question here. Is since CMS does not provide clear guidance on patient deduplication, I'm curious what logic your organization uses to determine which duplicated patient record is kept.
Yeah.
Go ahead.
Okay, I
And
like.
we have a number of different patient attributes that are used for matching. So again, we have, I'll let Bhushan kind of speak to that.
Yeah. So the the standard from our experience, what we have seen is having the first name, last name, and date of birth matching criteria works best across whether we are trying to match the patient internally across multiple EHRs or with member beneficiary file as well. So I think my suggestion would be to have it simplified with first name, last name, and date of birth combination.
Yeah. Again, CMS
Great.
hasn't provided guidance on what are the minimum number of attributes, but other options could be address, zip code, things like
Yeah.
that. Yep.
Very good. Well, unfortunately, we are out of time today. So if you have a question that was not answered, go ahead and drop that into the question module, and we're going to make sure that someone reaches out to you via email to make sure. Here's some additional resources on the screen, and of course, these will be also in the slide deck for ACOs that you can access on the MRO site. And then as we wrap up here, I wanted to encourage you all to head over to vbcexhibithall.com. And there you will be able to access the MRO virtual exhibit booth. And again, there will be a link to this directly in the slides. But you can read up on them, see what they're doing in the space. There's a lot of resources here, some videos explaining, and of course, reach out to them directly through that. And then finally, though, if you would like to reach out to either of our speakers today, their information is here on this final slide. I'm also happy to facilitate an introduction as well, if that's easier. So feel free to reach out to me as well. We hope you join us on the next one. We are going to have a part 2 coming up here. When is that happening? That is happening on the 28th of August at 1 p.m. Eastern. And so we dropped a link in the chat to where if you wanted to register for that, we hope that you do. And again, we're going to include that as well in the thank you email that we send out later with a link to this recording. Thank you all so much for joining. Thank you, James Bouchon, for a fantastic presentation. And we'll see you in part 2 on the 28th. Bye-bye now.
Thank you. Bye bye.